Good afternoon, and thank you for joining us. We have a great lunch and learn today planned, so thank you for joining us for navigating the challenges, understanding complications in chronic pancreatitis. It's hosted by the National Pancreas Foundation, and this is one of our key benchmarks to support education for health professionals to help our patients have a better quality of treatment and care. Many of you are probably familiar with our key programs, but we are gearing up for our 20th anniversary fellow symposium. We also have 185 centers of excellence. We also have our grant program and other patient programs for physicians and patients in person. So we'll look forward to those on our website, and you can always subscribe to our newsletter. If you have a chapter in your area or patients that are interested in being more involved, please allow them to connect with us. Cheyenne would be happy to get in touch with them. We're kicking off our Pancreas Bowl season. It's a great opportunity for our centers of excellence, our medical professionals, and our patients to get together and celebrate the work that we're doing and also the work that we have to do and provide fundraising opportunities to support MPF. So reach out to Cheyenne if you know anyone interested. Those of you that are in some of our key markets, we do have galas across the country. Our next one coming up in Boston is the end of this month. So we'll hope you'll join us if you are in market. Save the date on the calendars and stay tuned for more information about these Courage for a Cure award celebrations. I mentioned briefly before, but save the date and applications are live for our annual fellow symposium. It's in Tempe, Arizona in March this year. So please join us. Application deadline is a little bit earlier this year, November 23rd, so make sure that you share that. There are limited spots available, and last year we got a record number of applications, but please encourage your folks to apply. We would love to see you there. Again, if your Center of Excellence is interested in becoming more involved or hosting your own fundraiser, if you don't have a chapter in the area, if you're into pickleball, or if you have a community walk and you'd still like to fundraise, there's a website specifically for our Centers of Excellence that you can create your own page, and Carrie or Sockpaul or myself would be happy to help you get set up in that. So again, more ways to participate and support the National Pancreas Foundation so we can host more programs like this. Also, this and other webinars will be posted on our website and YouTube later on. I encourage you to look at our medical professional portal sponsored by AbbVie. We have several CME opportunities that are available for free. There are articles, shorts. We have some podcast now formats, in addition to short videos. So again, allows you some professional development, lower time commitment, and at your own pace. And we have lots of doctors participating in these, sharing great resources and content. So look at our medical professional portal. Again, to stay up to date on all of these items, feel free to follow us on social media. We are on all the platforms. And again, we have the Center of Excellence newsletter that goes out, as well as, a newsletter to our general public. So again, if you have patients or other staff that would like to get newsletters, please subscribe to those. Our next webinar is coming up October 22nd. Make sure that you register today. Again, it will be posted online afterward, but feel free to join us on another cancer-related topic. Again, in November, lots of activities coming up for Pancreatic Cancer Awareness Month in November. And today we have these fabulous doctors who have joined us, and I'll do a quick introduction and allow them to get started and lead this session today. Our first speaker is Dr. Julia McNabb-Baltar. She is a visiting associate professor of medicine at the University of Pittsburgh and a gastroenterologist at UPMC Presbyterian and Mercy Hospitals, where she serves as director of well-being for the Division of Gastroenterology, Hepatology, and Nutrition. She earned her MD from the University of Montreal, completed her training at McGill University, and received an MPH from the Harvard Chan School of Public Health. Author of over 46 peer-reviewed publications, Dr. McNabb-Baltar focuses on outcomes in pancreatic disease, prevention of recurrent acute pancreatitis, chronic pancreatitis, health maintenance, and the use of AI in managing pancreatic cysts. Our second presenter today is Dr. Allison Yang, is a clinical gastroenterologist, and she specializes in the multidisciplinary care of patients with pancreatic disease. Dr. Yang earned her BA from Columbia University, from the University of Illinois, and MPH from Harvard School of Public Health, and completed residency at the Mayo Clinic and fellowship at Brigham and Women's Harvard Medical School. Her clinical and research interests focus on pancreatitis, pancreatic cyst neoplasms, earlier biomarkers of pancreatic cancer, mobile health applications, and machine learning tools for pancreatic disease management. Thank you so much for joining us, and I'll turn the program over to you.
Thank you, Jenny. Appreciate this kind introduction. I appreciate this beautiful invitation to speak with all of you about this very important topic. So very briefly, I'm going to review our learning objectives for this next half hour. So our hope is that the viewers or listeners will be able to elaborate on complications of chronic pancreatitis, including identify the signs and symptoms of EPI, exocrine pancreatic insufficiency, understand the treatment of complication of chronic pancreatitis, including the management of pain, and we'll understand the psychosocial impact of the disease. But before we start talking about these, I'd like to first invite Ali to review with us the most common signs and symptoms of chronic pancreatitis.
Thanks so much, Julia. I think a key point to start with is that chronic pancreatitis isn't a single event. It's a continuum of injury to the pancreas that occurs over a period of time. And so it often starts with recurrent episodes of acute pancreatitis, acute inflammation, and this leads to a chronic, progressive, inflammatory, and fibrotic or scarring process of the pancreas. And this in turn leads to permanent structural damage to the pancreas, as well as loss of function, both exocrine function and endocrine function. So when patients first present to us, their symptoms can really vary significantly. Pain is very common. Some patients have the classic upper abdominal pain that radiates to the back, often worse after eating. Others might not have much pain, but instead they're showing signs of malabsorption. So they have greasy, foul-smelling stools, they have weight loss, they have bloating. Those are all clues that maybe there's something going on with the exocrine pancreas. Other less common symptoms, nausea, vomiting, bloating, weight loss, or vitamin deficiencies really are things that should suggest chronic pancreatitis. So that diagnosis really hinges on both the combination of symptoms as well as assessing risk factors. So we always ask about smoking, alcohol use, family history, and it's putting those pieces of the puzzle together that help us to make the diagnosis. So that's kind of what it looks like clinically, but of course, understanding why it happens is just as important. So Julia, maybe you want to walk us through some of the most frequent causes of chronic pancreatitis that people should keep in mind.
Yeah, absolutely. So I like to use the Tiger classification system to help me think of all the potential cause or risk factors that could be involved in our patients. So the T in Tiger stands for toxic metabolic, and it includes alcohol. So of course, alcohol is a big cause of chronic pancreatitis, but even when patients are taking, a small amount of alcohol and not a level that would be enough in itself to cause a chronic pancreatitis, but still a small amount could have detrimental effect on patients' case and evolution, even if it's just a cofactor. So we strongly recommend to avoid all alcohol intake, completely, anybody with concerns of chronic pancreatitis. Another toxic metabolic cause is tobacco smoking. And we do know that tobacco is multiplicative with smoking, and it has a strong effect on encouraging progression from acute to chronic, and as well as increasing the risk of getting painful pancreatitis and also developing pancreatic cancer. So we strongly advocate for smoking cessation, and there is a lot of programs that can be put in place to help our patients navigate this dependence, which is not easy to eradicate. Other toxic metabolic cause includes hypercalcemia, which we will often see with hyperparathyroidism. Hyperlipidemia as well can contribute. Usually we think of high triglyceride levels, and often this will present as triglyceride levels that are above 1,000 to cause acute pancreatitis, and then through the mechanism of recurrent acute pancreatitis, those patients can get chronic changes in their pancreas. So we try to get the triglyceride level as normal as possible, because again, even mild elevation in the triglyceride can lead to more complications and more diseases in our patients, even if that's not the primary cause of the injury. Otherwise, we think of chronic renal failure that can sometimes contribute, some medications as well, which again is through the pathway of recurrent acute pancreatitis, and then some toxins that can rarely be seen. So this is for the T in Tigaro. Then we have idiopathic, which is once you've had investigations, basically you don't know what the cause of the chronic pancreatitis. You can have early onset, which happens before the age of 35 and will often be associated with genetic predisposition that was not diagnosed yet. Late onset after the age of 55 usually, and also tropical chronic pancreatitis, which is a diagnosis we see usually in developing countries, most often in India. And this presents as young age with a lot of calcific disease, a lot of exocrine and endocrine dysfunction, and early demise, unfortunately. Then there's the G in Tigaro for genetic. So we know that there's a lot of different genetic factors that can contribute. There's the PRSS1 gene that will lead to hereditary pancreatitis, which is an autosomal dominant form of disease, where there is incomplete penetrance. So it's not going to be 100% autosomal dominant, but there still is a strong family history. And this is an important genetic cause to identify because those patients would be at higher risk of developing pancreatic cancer in their lifetime. Other genes that can contribute include CFTR, which is the gene causing cystic fibrosis, but this can also present as acute or recurrent acute or even chronic pancreatitis without a lung involvement. The SPINK1 gene mutation that can cause an increased risk of developing pancreatitis when there's other injuries, as well as others, including Claudin and others. Then there's the autoimmune cause that we think of when we either see other autoimmune condition or with the IgG4 related disease or type 2 autoimmune pancreatitis, and now even the type 3. So with IgG4 related disease, you think of the elevated IgG4, the other organ involvement such as retroperitoneal fibrosis, parotid gland involvement, sometimes biliary strictures. And those patients, they respond well to steroids. And this is something that's important to distinguish because those patients, you can really improve their exocrine and endocrine function with steroid treatment when they're identified early. Then we think of recurrent or severe acute pancreatitis. So this is either an individual that had necrotizing acute pancreatitis that then develop chronic changes or have recurrent episodes from other causes, as we mentioned, but also potentially from radiation treatment or vascular disease. And finally, the O stands for obstructive. So there you think of potentially duct obstruction from tumors, potentially sphincter of Oddi dysfunction, although this is becoming more of a controversial cause. Pancreatic divisum as well has become more debated. Potentially, if there is preampular duodenal wall cyst or groove pancreatitis, or post-traumatic pancreatic duct scars is something you will think of obstructive causes. So you can see that there sometimes are multiple factors involved, and you try to decrease all of those effects when you can.
Definitely. That's a really good overview of all of the causes. You've mentioned EPI a couple of times. Since EPI is such a major downstream complication, can you share more about some of the key signs and symptoms of EPI that we should be watching for?
Absolutely. So you think, as you mentioned earlier, steatorrhea with oily, bulky stool, foul-smelling stool. Sometimes you talk about stool floating around the water, difficult to flush. You can also see the oil at the top of the toilet. Sometimes it can present more as diarrhea, but sometimes patients can also have symptoms that are a lot less specific, and they can present with symptoms such as abdominal pain, cramping, bloating, or gas. So you can see that it's sometimes difficult to distinguish from our other patients that have irritable bowel syndrome with diarrhea. Sometimes you can also see symptoms and signs of vitamin deficiency. So liposoluble vitamin deficiency, we think of, for example, with vitamin A, the classic is the difficulty seeing in low light. They can also get, if they've had a long-term vitamin A deficiency, they can get those beetle spot, which is like when there's keratin building up on the cornea, the conjunctiva creates a little spot on the side of the eye. You can also see eye dryness that can present, such as corneal ulcers, as well as blindness. And they can also have impaired skin healing, dry skin, impaired wound healing sometimes, as well as infertility. With vitamin D deficiency, patients can, of course, present with metabolic bone disease, which is something a lot of people think of, but they can also present with bone pain, muscle weakness, sometimes cramping, sometimes fatigue or depression. For vitamin E deficiency, they can present with muscle weakness, loss of coordination. They can have some numbness as well as vision issues, and their immune system can also be weakened. And then the last one is vitamin K deficiency, which often will present as excessive bleeding or poor wound healing or internal bleeding, but it can also present as metabolic bone disease. And then, obviously, the patients can also present with fatigue, weight loss. And I think one thing that's very important to mention is that you can have exocrine pancreatic insufficiency and not have chronic pancreatitis. So EPI is not specific to chronic pancreatitis. Other conditions such as acute pancreatitis, which potentially is a stunned pancreas that will improve with time, or potentially associated with diabetes. And those conditions can also present with EPI and not have chronic pancreatitis as well. What I was thinking too is that, we know that there's a major complication of chronic pancreatitis, such as pain, that affects quality of life very significantly, right? And I was thinking maybe, Ali, you could run us through the different pain management strategies that can be used to help our patients.
Yeah, definitely. Chronic pain is probably one of the most challenging and life-altering complications of chronic pancreatitis. And it's challenging for both patients and for physicians. What's tricky is that the pain is often multifactorial. So it's in part inflammatory, in part neuropathic, and over time, it becomes centralized, where the whole nervous system itself is sensitized, and it amplifies these pain signals to cause significant pain for patients, not just in the pancreas, but elsewhere as well. In the very early stages, pain is really correlated with either inflammation on the pancreas from acute pancreatitis, recurrent acute pancreatitis, or chronic pancreatitis, or obstruction of the pancreatic duct itself. For example, if you have stones in the duct from chronic calcific pancreatitis, or if you have strictures, which are scars from chronic pancreatitis, think of the duct as a hose. If you have something blocking it like a stone, or if you have scar tissue like a stricture, preventing outflow of the pancreatic juices, that can increase the pressure inside the duct, increase the pressure upstream of where the obstruction is. That causes pain. And in those situations, really targeting interventions like ERCP, where we can go in and break up the stone or pull out the stone or dilate the duct, that can be really effective for treating that pain. But as time goes on and as the disease progresses, the pain often becomes less about the pancreas itself and more about nerve remodeling and central sensitization. So later on, our approach has to be multimodal, and it has to be really individualized to the patient. As Julia mentioned earlier when she was talking about the causes of pancreatitis, we really start with sort of the low-hanging fruit, the lifestyle and the medical management. Things like stopping alcohol, stopping smoking. These are things that we know can worsen outcomes in chronic pancreatitis, and these are things that we can cut out. Enzyme therapy for exocrine pancreas insufficiency, the data is a little mixed on whether or not that truly helps pain, but it certainly helps with pancreas function and can help with symptoms. And also then doing small, frequent meals can sometimes help with symptoms as well. These are simple measures that alone can make a big difference for some patients. When we need medications, usually we follow the WHO, the World Health Organization, step up pain medication scale. It's what they call a step up approach, starting with the least invasive, the lowest risk medications and escalating as needed. So that means that we're starting with non-opioid analgesics or pain medications first, things like Tylenol. And then we escalate to things like tramadol. And then we add agents that really target that neuropathic pain, those nerves. This is where things like pregabalin or gabapentin come into play, and sometimes even old antidepressants called tricyclic antidepressants. These all really work well on that nerve pain. The neuropathic nature of the pain is such that it's not necessarily an obstruction or acute inflammation. It's the nerves that are sensitive around the pancreas. And so by targeting those nerves, you can help dampen the pain response. For refractory cases, we do sometimes consider procedural options. Obviously, endoscopic therapy if there's a clear obstruction that we can relieve. Sometimes we'll do what's called a celiac plexus block, which blocks that nerve center that causes the pain, and the hope is that we're interrupting the pain pathway. And so we inject a little alcohol or steroid into that nerve plexus to try and block those nerve signals. In very select cases, we sometimes will work with our surgical colleagues to talk about surgical procedures that either relieve the obstruction. So if they have big stones or big strictures in the duct, we can do surgical procedures to relieve that obstruction. And sometimes we even start talking about total pancreatectomy with islet autotransplantation, which is where we remove the entire pancreas and then we infuse back the islet cells into the liver to help with both pain control. So if you remove the pancreas, you can help with some of that pain, not the neuropathic component, but the pancreas component itself. And then we give the islet cells back to help try and maintain insulin production. That can be life-changing in the right patient, the patient who really would benefit from this type of procedure. But it really does require careful patient selection and an expert center to do this. In some cases, we do require opiate therapy, and that's okay too. We work really closely with our pain management colleagues to give opiates. There are also clinical trials in process looking at other things. So one of the trials is looking at lacosamide, which is an anti-epileptic medication used in conjunction with opiates to hopefully relieve pain in patients with chronic pancreatitis. The thought there is if you give another medication, it can help augment the effect of the opiate so you don't have to take as much of the opiates. There are also other more immune modulating medications that are being studied currently that are hopefully going to be on the horizon in the next couple of years, targeting other pathways, other inflammatory pathways that in hopes of relieving inflammation or relieving fibrosis or scar tissue to help manage pain. Throughout all of this, the other really important piece as physicians is setting expectations and supporting patients emotionally. So chronic pain management is a marathon. It's not a sprint. We're not going to solve this in a day. Our patients often really struggle with anxiety, depression, fatigue. When pain dominates daily life, it really affects everything from appetite to sleep to relationships. The National Pancreas Foundation and other chronic pancreatitis foundations have put out surveys to patients assessing their pain, and overwhelmingly, pain is the most commonly reported symptom, and it really makes a huge difference in terms of quality of life. When you're in pain, the rest of your life is affected too. So pairing medical management for the pain with behavioral and psychological support for our patients is also really key. Ultimately, the goal is not only to suppress pain, but to restore function and quality of life and to help patients feel like themselves again. And so managing pain is a huge part of what we do. Of course, it's not the only challenge. We work in conjunction with lots of people. Chronic pancreatitis affects so many other systems beyond the pancreas itself. Julia, maybe you can take us through some of the other complications of chronic pancreatitis that clinicians should be keeping an eye out for.
Yeah, absolutely. So a big one is diabetes, so diabetes 3C. And we can see this in up to 75% of the patients with chronic pancreatitis during their lifetime. And I think one thing that's important about this type of diabetes is that it can be a brittle type of diabetes because it's not only insulin, but also the glucagon that is lost. So the patients will have very low lows, very high highs, and it's going to be very difficult to control. So they need to work very closely with their endocrinologist to help with that. And before patients become diabetic, it's going to be important to do very regular screening, at least annually, because of their very high risk of becoming diabetics. Patients with chronic pancreatitis are also at very high risk of developing osteoporosis compared to the general population. In pooled prevalence, the rates of osteoporosis ranges from about 19 to 23%. And osteopenia is 37 to 41%. So if you put them together, it's more than half of the patients with chronic pancreatitis that have metabolic bone disease. So again, it's important to screen. The guidelines are not that clear about when and who should be screened, but definitely, postmenopausal women, patients that have exocrine pancreatic insufficiency, if they've had low trauma fracture, they should definitely be screened. And there's some experts that do recommend screening on diagnosis with DEXA scan and also doing it regularly, potentially every 2 years to monitor. Myself with the group from Ohio State, we looked at using CT scan to look at the Hounsfield unit at the level of the vertebra to estimate patients that are going to be at higher risk of developing osteoporosis. And this good data suggested that this could be a nice way of starting the screening, but obviously there's more data that needs to be done about this before this can be recommended more universally. But one thing that's important is that there's a lot of lifestyle stuff that can be done to help patients with chronic pancreatitis before they become osteoporotic. So making sure that they are not vitamin D and K deficient, making sure that they stop drinking and smoking, because smoking and drinking also affects the risk of having metabolic bone disease. Also engaging in regular weight-bearing activities. So we recommend 20 to 30 minutes daily of weight-bearing exercise. So that includes walking. So it doesn't need to be high stress exercise, but walking at a brisk pace, as long as the primary care doctors are on board with this and the person's health it works with this. So that's another important complication that we can see. Another one that makes patients with chronic pancreatitis especially nervous is the risk of pancreatic cancer. So overall, the risk of pancreatic cancer is 3 to 8-fold increased in patients with chronic pancreatitis. And the cumulative incidence is about 2 to 4% over 10 to 20 years. And we know, as I mentioned a bit earlier, that the risk is much higher in patients with hereditary pancreatitis, which is up to a 7% lifetime risk by the age of 70. At this point, there's no screening recommendation for pancreatic cancer in the overall chronic pancreatitis population. It will be recommended in a patient with hereditary pancreatitis. Also, if there's a new diagnosis of diabetes within the first 2 years, and then also, if there is a family history of pancreatic cancer on top, those patients will be at a higher risk too. So in those populations, we recommend, depending on guidelines, with the recommendation is between MRCP or endoscopic ultrasound, potentially alternating every 6 to 12 months, depending on the situation. But this is something to be discussed with your provider. Another common complication is the development of pancreatic pseudocyst. So this can sometimes present with worsening and new onset pain. And so a good quality cross-sectional imaging can show you if there is a cyst that develops, and then if there's a cyst that we think is contributing to the pain, it can be potentially drained endoscopically or sometimes surgically or by radiology, depending on the location. And the treatment approach is best done when there's a multidisciplinary team sitting together and reviewing the situation to evaluate what would be the best approach to the specific patient, so that it's really patient-centric and individualized and tailored to the need of the specific patient. Other complication includes a bile duct obstruction. So in this case, patient will present with new onset of jaundice, and there will be sort of a mass in the head of the pancreas compressing the pancreatic duct. And this can be relieved with ERCP, with a stent placement, potentially also with a surgical intervention from our colleagues from surgery to relieve the obstruction and remove that part of the pancreas, the head of the pancreas, if it's causing issues with the bile duct. It can also present with duodenal obstruction. And in that case, patients will have symptoms of gastric outlet obstruction. So they will present with fullness, nausea, vomiting, early satiety, weight loss. And in that situation, if the inflammatory mass is not able to resolve with conservative treatment, again, sometimes they will need a surgical intervention to help them with this condition. And now if we do a transition a little bit and talk more about EPI, which is an important component of the management of chronic pancreatitis. Ali, can you walk us through EPI and vitamin deficiency management?
Yeah, absolutely. And we actually just got a question in the Q&A about EPI and PERT dosing. So this is the perfect time to address it. So let's take a step back for a second. What's happening physiologically in exocrine pancreatic insufficiency is that the acinar cells on the pancreas, the ones that make digestive enzymes to break down food, they get progressively damaged and replaced by fibrosis or scar tissue. And so over time, the pancreas simply cannot make enough enzymes to digest fat, protein, and carbohydrates properly. The ductal cells, the ones that make bicarbonate-rich fluid, also are affected. And so they're maybe not making enough bicarbonate-rich fluid to create the optimal environment for the function of these digestive enzymes. And so clinically, as we mentioned before, it shows up as malabsorption, maldigestion, greasy stools, bloating, cramping, weight loss. Sometimes the symptoms are very, very subtle. And sometimes EPI doesn't occur in chronic pancreatitis. You can get EPI even without chronic pancreatitis. From a diagnostic standpoint, fecal elastase is a very widely used stool test. While it's not perfect, it's a good screening test for exocrine pancreatic insufficiency. The key to note is that it has to be done on a formed stool. If it's done on a watery stool, it can come back artificially low. When it's below 100, that's really what makes us start thinking about EPI. You can also do what's called a 72-hour fecal fat collection, which sounds exactly like what its name would suggest. You collect stool for 72 hours. This is another good way to look for how well your body is digesting fat. And sometimes we can't do stool at all because the stool is just too watery and we can't get a good fecal elastase. An MRCP with secretin is a reasonable functional MRI to really look at the function of the pancreas without having to do stool. When you talk about managing EPI or exocrine pancreatic insufficiency, the cornerstone of management is replacing those pancreatic enzymes and what we call pancreatic enzyme replacement therapy or PERT. The key is getting both the dose and the timing right. And so usually we're aiming for somewhere between 40 to 50,000 units of lipase. And so if you're starting with Creon, for example, I like to use the 36,000 unit of lipase capsules, and we're giving 1 or 2 with each meal as a start, depending on the patient's size. So if they're over 70 kilos and giving 2 capsules, if they're really small, we're giving 1 capsule, and we give about half of that dose with every snack. I always tell patients, enzymes work by mixing with the food that needs to be digested. So the goal is for the enzymes to reach the small intestine at the same time that food reaches the small intestine. And as you can imagine, this is an art and not a science, because how well your stomach empties and how quickly it empties is going to be very different for everyone. So the enzymes need to be taken with food to start, not after a meal, not randomly in the middle of the day. You want to take the enzymes with food. And usually I tell people to take the first capsule with the first bite of a meal, and another capsule a couple of bites into the meal. For people who continue to have symptoms, sometimes it's a matter of both education and adherence. So making sure they're taking enough capsules, taking them correctly, not skipping them with snacks. If you still have steatorrhea, the loose oily stools, or symptoms despite adequate dosing, sometimes we'll switch to a different formulation. Or sometimes we will add a proton pump inhibitor, which is an acid suppressing medication to help reduce the acidic breakdown of the enzyme. So often we switch to PERTZI, which is a different formulation with different bicarbonate levels, or we add a PPI. Beyond enzymes, we obviously want to focus on nutritional optimization. So supplementing fat-soluble vitamins as needed, maintaining adequate protein and calorie intake. Taking pills with every meal can be exhausting. And so the education part of helping patients understand why it matters, tailoring the plan to their lifestyle also really improves long-term outcomes. Managing EPI really just highlights how complex chronic pancreatitis can be. It's not just one organ or one symptom. It's nutrition, metabolics, emotionals, all these layers that intersect. Julia, with all these complications in mind, what do you think a multidisciplinary care team ideally looks like for these patients?
Yeah, it's a great question. And I think it's the perfect type of situation where the multidisciplinary team will come together to really tailor treatment and be individualized to each patient. So you want a gastroenterologist, a medical pancreatologist like me and Ali, if they're available in your center, an advanced endoscopist, a surgeon, a radiologist, a pathologist, a nutritionist, a psychiatrist, a psychologist, to all come together and think of the best way of treating the different components that we've mentioned so that the patient can really achieve the best potential outcome. And as Ali was saying, we're aiming for is to improve quality of life, not necessarily completely suppressing symptoms, but improve quality of life so that the patients are able to get back in their life and their swing of things, because it could be an extremely debilitating disease and condition, as you can imagine. So I think definitely there's a huge impact from the level of the psychosocial impact of this disease. So it's associated, as we said, with a very high rate of depression, anxiety. There's also a lot of pills that need to be taken, especially if there is EPI and pain and diabetes. And so this is a lot of pill that needs to be taken with every meal. And if there's not a good adherence, there's not going to be ideal symptom control with this. And it could also be associated with nutritional insecurity, financial insecurity, social insecurity, because it's difficult to live your life with the symptom burden and have a very supportive environment. So it's a very, very difficult disease for us. And I think we're both very happy to be involved to try to help those patients as much as we can in the ways that we can.
Yeah, absolutely. The emotional and practical burden can really be very overwhelming, and supporting that side of the care is really just as critical as treating the pancreas itself. With our time in mind, I'd love to end with a few key takeaways for clinicians just managing these patients with chronic pancreatitis. First, we want to recognize the full scope of chronic pancreatitis. It's not just about pain, it's about maldigestion, diabetes, bone loss, pancreatic cancer risk. Thinking broadly helps us to pick up these complications earlier and support our patients more comprehensively and completely as a whole person. Second, EPI is both really common and highly treatable, but it's often missed. And so if a patient with chronic pancreatitis has weight loss, bloating, or nutritional deficiencies, don't hesitate to test and don't hesitate to start enzymes. Correct dosing and adherence can really change outcomes. And third, care really has to be multidisciplinary. Like Julia said, the best results come when gastroenterologists, dietitians, endocrinologists, pain management doctors, mental health professionals, we all work together. Nutrition and mental well-being are just as critical as enzyme dosing or endoscopic interventions. And finally, we always have to remember the patient experience. Living with chronic pancreatitis is hard. The constant pain, fatigue, the pill burden, this all takes a toll. So empathy, education, practical support really go a really long way towards improving quality of life. So early intervention, early recognition, comprehensive management, and the whole person approach, that's really how we make a difference to people living with chronic pancreatitis. I think we've had a couple of questions in the Q&A, so we want to try and get to some of those as much as we can. Julia, one of the questions is, what do you do if you can't find a pancreas specialist?
Oh, yeah, that's such a good question. So, but I think, first of all, the National Pancreas Foundation, with the chapters and the centers of excellence that are being developed across the country, is absolutely an amazing resource for patients. I would say go there and see, because there's a lot of people that have this interest, and there's more and more centers popping up. And potentially there is a center close to you that's able to help. So that I would say that's a fabulous resource in that situation.
Yeah, for sure. And I think there's an email that's going to be sent out after this that will have a link to the NPF's list of centers of excellence. One of the other questions is about GLP-1 drugs. I guess I'll answer this one. Starting a GLP-1 and triggering symptoms of chronic pancreatitis. This is a question we actually get a lot now with increasing use of GLP-1 receptor agonists, medicines like Wegovy, Mounjaro, Zepbound. Early on, there were case reports suggesting a possible link between GLP-1 medications and pancreatitis. And because of that, the whole class of drugs actually carries a warning about use in patients with a history of pancreatitis. There have been some more recent, larger population studies that haven't shown a clear increase in the overall risk of pancreatitis compared to other drugs. But that being said, these drugs do still cause GI effects. They can cause nausea, bloating, early satiety, abdominal pain, and all of these can mimic symptoms of pancreatic disease. So if a patient on a GLP-1 has abdominal pain, we want to take it seriously. We want to rule out pancreatitis with labs, with imaging. But also we want to recognize that it may not be true acute pancreatitis. It can still be abdominal pain from the medication from the medication itself. So the evidence doesn't show a really strong causal link, but if a patient on a GLP-1 develops abdominal pain, they should still get evaluated because there are other GI side effects. And usually we end up needing to have a conversation about whether or not to continue the medications. If you already have known chronic pancreatitis, this is where a good risks and benefits discussion is required and needs to happen with your gastroenterologist before staying on the medication.
Yeah, and I'd like to add too that GLP-1 will cause muscle loss, and you can see weight loss and muscle loss from the medication itself too. Otherwise, I completely agree with what Ali said. Absolutely. We see this a lot in practice.
Absolutely. There's some other questions here. Let's see. Pancreatic cancer risk with chronic pancreatitis. I think Julia mentioned that. What about managing pain after a dietary trigger meal?
That's a really tricky situation because there's not good evidence supporting a low-fat diet in patients with chronic pancreatitis. I think the way we see it is you kind of individualize with patients. So if you see that clearly there's something that triggers this specific patient, you can try to cut down on it. But as a general rule, we don't want to do a low-fat diet with patients with chronic pancreatitis. We want to supplement with exocrine, with the enzymes like the exocrine function, as Ali was discussing. I think that's the key point there. Sometimes hydration can help in terms of dietary modification. If the patient also has gastroparesis, which happens sometimes with chronic pancreatitis, you can also do small frequent meal, separate liquids from solid, avoid very high fiber foods or very fatty foods because they stay longer in the stomach. That could be a situation where it can be helpful. So you spread them out a bit. And also avoid like very high glycemic index food, like white potato, white bread, because that can sometimes trigger symptoms, but there's not a lot of high quality evidence in terms of the nutrition.
Yeah, there's another question about controlling nausea with chronic pancreatitis. This is also hard, and I think touches on what Julia was just mentioning with sometimes there's delayed gastric emptying, so checking for that can be really helpful. Small frequent meals can also be helpful. There's the idea of maybe resting the pancreas a little bit with these small frequent meals. But like we said, we don't really restrict what people eat. It's more supplementing as needed. And then maybe we'll conclude with one last question. There's a question, is there evidence that chronic pancreatitis can cause autoimmune disorders? Chronic pancreatitis itself shouldn't cause autoimmune disorders. There is an entity, like Julia mentioned, called autoimmune pancreatitis. It's an immune-mediated form of pancreatitis that's associated with other organs as well. This can lead to chronic pancreatitis, so it is important to remember that as part of your evaluation, because you don't want to miss autoimmune pancreatitis, and it's treated differently, like Julia mentioned, with steroids. But this has been a great talk. I love chatting with you, Julia, about chronic pancreatitis.
Me too.
And
we should do this again.
We should. I'm so glad that there are so many of you here to join us to talk about chronic pancreatitis. And thank you for taking the time out of your workday to join us for this webinar on chronic pancreatitis.
Thank you. Thank you. Appreciate your time.